All right, so we're going to jump into psychopharmacology at this point, and kind of the overview of what I'm going to talk about in Chapter 4 deals with some of the basic principles of psychopharmacology. We'll talk about sites of drug action, and we'll talk about neurotransmitters and neuromodulators. And so I think probably a lot of this kind of overlaps with brain and behavior to some degree, but I think it's super important to have a really good handle on the neurotransmitters and how drugs act, because as a neuropsychologist, I often have to understand how various drugs work and the mechanisms of action and things like that. So if you have a good handle on what is going on in Chapter 4, then you'll be at a really good point to understand how drugs really work, what their mechanism of action is. So just some definitions. We talk about neurotransmitters and neuromodulators, and neurotransmitters communicate across a synapse only a very short distance away. Neuromodulators, by contrast, are also released by neurons, like neurotransmitters, but they travel a little farther and they're dispersed a little bit more widely than neurotransmitters. And most of the neuromodulators that we see are peptides or amino acid chains that are linked by peptide bonds. And generally speaking, neuromodulators affect general behavioral states like vigilance, fearfulness, and pain sensitivity. The third major method of chemical communication include hormones, and these are secreted by endocrine glands or cells in various organs, and the hormones are sent not into a synapse, but they're sent into the bloodstream, and their action is distant from usually fairly distant from the site of release, in contrast to neurotransmitters and neuromodulators, where the site of action is relatively close to where it's released. We have two different types of hormones, as I mentioned last time. We have peptide hormones that stimulate more metabotropic receptors in the membrane far away from its site of release, and steroid hormones that pass easily through the cell membrane because they're lipid soluble, and they travel to the nucleus where it directs the cell to alter its protein production and can actually have an effect on the protein production directly, whereas the peptide hormones have to use that second messenger system via the metabotropic receptor. So a drug simply is an exogenous chemical that comes from outside the body, and it alters functions of certain cells, and the effects of a drug are the changes that a drug produces in an animal's physiological processes and behaviors. And these drug effects can be usually positive, like relief of pain, or it could be more negative, like suppression of respiration. And so we just have to keep those different drug effects in mind. And then when we talk about a site of action, we're talking about the locations at which molecules of drugs interact with molecules located on or in cells of the body, and thereby affecting the biochemical processes of those particular cells. When we're talking about psychopharmacology, we can sort of break it down into two large branches. One branch is called pharmacokinetics, and the other is called pharmacodynamics. The pharmacokinetics are usually very intensively studied for any drug and simply refers to the movement of drugs as they come into the body and as they go out of the body. And in particular, we're interested in looking at how the drug is introduced into the body, how it can be absorbed, how it can then be distributed throughout the body, how it can be metabolized, and then how it's excreted or gotten rid of. When we're talking about pharmacodynamics, we're talking about a dose-response effect, looking at biochemical and physiological effects of the drug on the body, as well as the specific mechanisms of action. So pharmacokinetics is very much separate from pharmacodynamics. So to jump into pharmacokinetics, again, we're looking at absorption. So how is the drug taken into the body and absorbed through the tissues? Distribution is how is the drug distributed throughout the body and the blood. Metabolism, how is the drug changed or converted to an inactive form, usually by enzymes in the liver most often. And then excretion, how is the drug excreted from the body? Usually it's through the kidneys, although it could be through the sweat or could be through respiration, for example. Now, in terms of routes of administration, getting the drug into the body, there's a lot of different approaches that people can use to try to get a drug into the body. And it's important because if a drug has a very powerful effect, we might want to not deliver it to the body all at once. We might want to find ways of slowing the absorption so it's not quite as much of a shock to the system. Now, the intravenous injection or IV injection lets the drug reach the brain in just a few seconds, and the entire dose hits the brain all at once. And so you have to be very, very careful with intravenous administration of drugs, particularly drugs like morphine for pain relief. An intraperitoneal or IP injection is when we inject the drug directly through the abdominal wall. It causes rapid drug delivery, but it's not quite as fast as the intravenous delivery because it has to be absorbed through the capillaries of the gut. Yeah.
Is the bioavailability of all drugs when they're intravenously injected 100%, or is there differences in bioavailability?
The bioavailability is really governed by the lipid solubility of the drug, all of what you inject is right at knocking at the brain's door just a few seconds after you inject it with an IV injection. So the extent to which it actually crosses the blood-brain barrier and gets into the brain is dependent on its lipid solubility, we'll see. There's also other factors like the binding to albumin in the blood and things like that, or depot binding as it's called. The intramuscular injection is a little bit like the intraperitoneal injection, although it's still, the drug is absorbed maybe a little bit more slowly yet. We could actually mix our drug with a different drug that constricts the blood vessels, like ephedrine, if we want to slow down the absorption of that drug. Subcutaneous injection, or SC injection, is just given the drug with an injection right under the skin, and that's usually only useful if we want to administer very small amounts of the drug. If we need to administer a large amount, your person's going to have a big puffy kind of bulge under their skin, and it won't be very comfortable or very helpful. Sometimes people dissolve a fat-soluble drug in vegetable oil, or they place the drug in a dry pellet or a rubber capsule and put it under the skin to try to slow absorption. In some cases, that's used with some contraceptive types of medications to have that drug be absorbed at a very slow rate. So kind of going further out, a transdermal administration or a patch can often be used. Here the drug can be mixed with alcohol or dimethyl sulfoxide or something that could enhance the penetration of the drug into the skin, helping to carry the drug into the skin, and the drug passes then to the bloodstream without needing the injection. And in this way, you can actually control the rate at which the drug is delivered, and so it can be slowly and continuously delivered for many hours to days or weeks. And the other benefit of transdermal administration is it usually keeps blood levels of the drug constant, as opposed to having rapid peaks and troughs in terms of the availability of the drug. And these are very good for drugs that are rapidly eliminated from the body so that you can have a continuous supply of the drug. But the downside is that sometimes the adhesive for the patches can irritate the skin of people and the effectiveness is really limited by how fast the drug can pass through the skin. There's an anticholinesterase medication that is in a patch form, and sometimes many of the it's used for Alzheimer's disease, and sometimes one of the side effects of these medications is nausea and diarrhea. And so to avoid some of the GI side effects, I think the patch avoids the GI system, and so it again keeps the blood levels of the medication constant, and I think is sometimes a lot better than the oral pill form of the medications. So these are just the example of the different routes of administration, going from subcutaneous, just under the skin, to intramuscular, to intravenous. This is the vein, sort of right along here. This is your muscle. And transdermal, or the patch, is on top. And then implantation is kind of underneath the skin also, but in a form where the drug is released very, very slowly into the vasculature. The oral administration of a drug is most common for humans, and it can't, though, be used for some drugs that could be destroyed by stomach acid. So that's why they don't have a pill form of insulin, because insulin would be digested by the stomach acids, and that's why it has to be injected. Sublingual administration, the drug is placed under the tongue and is absorbed by capillaries that supply the mucous membrane that lines the mouth. Nitroglycerin is a good example of a drug that is often put under the tongue and absorbed through the capillaries in the mouth. Intrarectal administration or suppositories can be used if the drug might cause stomach upset, or it would be inactivated by digestive enzymes, or if taking by mouth is impossible. In fact, when I was on the epilepsy surgery team, we would have patients who would have continuous epileptic seizures for a long period of time, and that's called status epilepticus. And if people are in status epilepticus, we really want to have some way of stopping their seizure. And so giving a benzodiazepine like Valium is usually one of the treatments of choice. And if the person is having a seizure, there's no way to really get the Valium into their mouth, and they're having a seizure, so it's very difficult to do an intravenous administration. So sometimes a suppository of Valium can be very helpful in that particular scenario. That's an emergency situation.
How long does it take to affect them?
For the intrarectal or the suppository form, it would probably, I think it takes about 5 to 10 minutes to really get absorbed.
What about the sublingual?
Sublingual, about the same time, yeah. Mm-hmm.
Is sublingual the same as buccal? So is it the mucous membrane in the lining of the mouth?
Yeah.
Under the tongue?
Yep, yep.
Okay. So they're the same.
They're more prominent right under the tongue, and so that's
everywhere.
yeah. But yeah, they would be absorbed if you just held it in your cheek, or in your front of your mouth. But usually people put it under the tongue.
So will there be a huge difference between intraperitoneal and oral? Because from my understanding, the intraperitoneal is straight into the gut. That's where the drug is being injected. So when you swallow something, that's where it's headed as well.
Yeah, there's a big difference, and that's that you avoid the digestive enzymes with the intraperitoneal. You're really not injecting it into the stomach through the abdomen, but you're injecting it into the space that surrounds the intestines, and so it's avoiding those digestive enzymes. So insulin could work in a manner like that, for example. And a lot of drugs are administered trying to get the drug close to the desired site of action. like intravaginal administration, like tablets, creams, gels, or suppositories. And these are often used to administer estrogen at menopause to help prevent the thinning of the vaginal wall that accompanies the decrease in normally cycling estrogen during menopause. Ocular route is putting liquid gel or ointment into the eye for local effects. Obviously there are some medications that are used to dilate your eyes that you can dilate your eyes via several different methods, but you want a local effect of that dilation rather than more of a general effect that other medications might have that would also dilate your eyes. The nasal route is when you basically sniff the drug, and the drug contacts the mucous membrane lining the nasal passages. And typically has to be in an atomized form as opposed to a liquid form for best absorption. Little nose sprays, nasal sprays, things like that enhance the absorption.
Does the chemical need to be water soluble if it's going to the nose?
No. No, because there are actually steroid types of sprays that are sprayed into the nose that are absorbed. But yeah, it doesn't need to be water soluble. It does have to be, as I mentioned, atomized though. Unfortunately, commonly abused drugs are sniffed, like cocaine, for example, sometimes heroin, and the snorting that people know, that term, the technical term is insufflation for sniffing drugs like that. Now, sniffing drugs like that is different from inhaling drugs because the site of absorption is very different. It's not in the insufflation, it's being absorbed through the mucosa in the nose, but in inhalation, it's being absorbed through the lungs. So either a vapor, a fine mist, a gas, or smoke is typically used for inhalation. And the smaller the particle, the deeper the drug can enter the lungs. It delivers the drug to the bloodstream very rapidly. And the peak, we see the peak goes up actually quite quickly compared to the oral route, for example. The cutaneous or topical route, which sort of is akin to the transdermal or patch delivery. We have the drug that's applied directly to the skin in the form of an ointment, lotion, powder, gel, or lotion, and that'll provide a local effect. So there are sometimes local anesthetic agents or warming agents or cooling agents that can be delivered where we want to, again, use a cutaneous form of delivery of the drug to the body. Sometimes there can be an intracerebral administration where the drug is injected into a specific region of the brain, and this is very good, especially for observing the local effect of the drug and whether it has trouble crossing the blood-brain barrier. Intracerebroventricular or ICV administration is where we inject the drug not into a specific brain region but into a cerebral ventricle. And the drug can be absorbed by brain tissue to then exert its effects. And it's used oftentimes to administer antibiotics for certain grave conditions in humans. Intrathecal injection involves an injection of the drug under the arachnoid membrane of the brain or under the arachnoid membrane surrounding the spinal cord. This is just a diagram showing the different peaks and concentrations of cocaine in the brain, actually the plasma concentration roughly, for intravenous, smoking, oral route, and intranasal route. And you can see with the intravenous administration of cocaine, the plasma concentration is really the most. And so it's a way of getting kind of the highest plasma concentration. And we can see that it falls maybe a little bit more rapidly than intranasal or oral routes of administration. Smoking also has a very rapid peak after administration, but the plasma concentration isn't nearly as high as it is for intravenous, presumably because a lot of the material is burned in the process of producing the smoke. And so, again, it sort of provides the fastest decline in plasma concentration of the drug. The oral administration, you can see that it takes a little bit of time for it to reach a peak, quite a bit longer than the intravenous or the smoking approach. And the effect, actually, the plasma concentration decreases much more slowly compared to the first two. Then intranasal administration or insufflation or snorting, we can see also has a peak that's sort of a little bit less than oral, but a little bit longer, takes a little bit longer than smoking, and it also maintains its plasma concentration for the longest time. So clearly different routes of administration very much affect the plasma concentration of the drug and the duration that the drug is in the body. So now we get into the bloodstream. Now what happens? So at this point we're looking at absorption, and lipid solubility, as I mentioned earlier, is the most important factor that determines how quickly a drug reaches the site of action in the brain, and sort of reflects more its bioavailability. The blood-brain barrier, we have to keep in mind, is only a barrier for water-soluble molecules. Lipid-soluble molecules are able to cross the blood-brain barrier very easily because the cells lining the capillaries and the central nervous system are basically have an outside lipid layer, and lipids love to go right through that. Heroin has a little bit more lipid solubility compared to morphine, so an intravenous injection of heroin is going to produce faster effects because it's going to get across that blood-brain barrier much faster. So once the drug is inside the body, then it's then metabolized and presumably excreted. And typically our drugs are deactivated by enzymes in the liver for the most part, and then they're eventually excreted by the kidneys again for the most part. The blood and the brain also have enzymes that deactivate drugs, and the enzymes can be capitalized upon in a lot of ways because you can take a biologically inactive substance, and if you know how it's going to be metabolized by the liver, it could actually be biologically inactive when it goes into the body, then metabolized to a biologically active substance. On the other hand, you can have a biologically active substance that is injected into the body and it does its thing, and then the enzymes in the liver deactivate it and allow it to be excreted. So a lot of drug developers kind of play upon these the role of enzymes in the body to cause these different changes to various drugs that they develop. So that's kind of the end of pharmacokinetics. We're talking about the movement of drugs into and out of the body. And now we're getting into more of the pharmacodynamics, or the drug effectiveness. And so here we're talking about the dose-response curve. The dose-response curve is just a graph of the magnitude of a particular effect of the drug as a function of how much drug you administer. And the effects of the drug can be very different. There are different dose-response curves that exist for different drug effects. And the dose-response curve is really the best way to measure the effectiveness of the drug. Generally, we try to standardize the dose in terms of milligrams per kilogram so that we know for what the drug's effect is per kilogram of body weight. Many drugs obviously have more than one effect, like morphine. Morphine has one effect of pain relief, and it also has another effect of respiratory and cardiac depression. So we want to be kind of careful that we maximize the pain relief part and we minimize the respiratory depression part. This is a graph of a dose-response curve, and as you can see, it's a little bit sigmoidal in nature, and increasingly stronger doses of the drug produce larger effects of whatever the effect is, until a maximum effect is reached. And after that point, the more drug we give won't really have any changes in the effect of the drug, but as we increase the dose of the drug, we increase the risk of adverse side effects. This illustrates the dose-response curve for a positive type of effect of a drug, pain relief or analgesia, and this is a dose-response curve for the depressive effect of morphine on respiration. And we have this other concept called the margin of safety. And here, this margin of safety is reflected by the difference between the dose-response curve for its therapeutic effects on the left and for its adverse side effects on the right. Drugs that have a very narrow margin of safety are you want to be very, very cautious in using those, but where there's a large difference in the margin of safety, they tend to be safer types of drugs. So the therapeutic index is the ratio between the dose that produces the desired effect in 50% of the animals and the dose that produces toxic effects in 50% of the animals. And if the toxic dose, or LD, they call it, or lethal dose, is 5 times higher than the effective dose, or ED, then the therapeutic index would be, in this case, 5. The lower the therapeutic index, the more care that has to be taken when you're prescribing the drug. So drugs with the same behavioral effects may have different sites of action or different mechanisms of action. For example, we have morphine and aspirin, and both of them produce analgesia. But morphine produces analgesia by suppressing the activity of neurons in the spinal cord and the brain that are involved in pain perception, whereas aspirin decreases the production of a chemical that's involved in inflammation that transmits information from damaged tissues to pain-sensitive neurons. So again, drugs don't always act in exactly the same way. They can have very different mechanisms of action, and they can have very different sites of action, one being more local and one being more central in the brain. And then we can talk about the affinity of drugs. The affinity or the readiness with which two molecules join together differs between drugs and their sites of action. So high affinity binding drugs will usually produce effects at very low concentration. So we always have to keep the affinity of the drug and the site of action in mind. With repeated administration, sometimes a drug's effects will lessen. And we see that a lot with the opiates, whereas people seem to need more and more of the drug to achieve the same behavioral effect that they're seeking. Some people can get to a point where they're taking so much of the drug that to get the desired effect that it would be at a dose that would probably kill somebody who had never taken the drug before. So it can be very serious, and this is the tolerance that develops. Withdrawal from the drug produces symptoms that are often opposite to the effects of the drug as the body attempts to compensate for the drug's effects. So whereas heroin can produce a lot of behavioral inactivation during withdrawal, you have a lot of behavioral activation, hallucinations, sweating, and considerable discomfort as opposed to the analgesia that heroin would otherwise produce. There are some drugs, though, that the effects actually become greater with repeated administration, so people become sensitized to those drugs. And some effects of drugs produce both sensitization and tolerance. It's important to also mention the effects of placebo, and I find the effects of placebo fascinating. Placebos are compounds that are intended to have no physiological effect, yet they actually seem to produce a physiological effect, even though they are biologically inert. A lot of these are related to expectations. So if we have a hope or some kind of expectation that a medication or a substance, rather, will produce an effect, we're more likely to see that effect. There can be external factors, like what a person sees. If they see themselves being injected with a placebo, even though they know it's a placebo, they're likely to feel some sort of a benefit from it if that's what they're led to believe. People who are told that an injection of a placebo will make them calmer, get calmer. And people who are told that an injection of a placebo will make them more active, become more active. In fact, there's some research cited by Irving Kirsch in your textbook. He was on 60 Minutes, and he wrote a book called The Emperor's New Drugs, referring to the selective serotonin reuptake inhibitors that are used for treating depression. And he has found, he's done a lot of research with placebo. He finds that the effect of the SSRIs is no greater than placebo for treating depression. And I guess it's amazing that these drugs that have side effects are marketed when in fact they're really operating largely through placebo, through placebo effects. In cases of severe depression, I think he has pulled back a little bit and said that they may have some action. But it's interesting that the whole goal of the SSRI medications is to keep serotonin around longer, keep serotonin from being taken back up. And there's never been a documented study that shows that depressed people are low in serotonin to begin with. What the rationale I find kind of troubling for those medications. But Kirsch has actually given placebos to people and said, this is a placebo, this is a biologically inactive substance, but sometimes people feel better and are less depressed after the placebo. So he actually prescribed the placebo, and the people on placebo got better, and the people who weren't treated with anything stayed the same. So it's a real effect, and it's an important type of, it's kind of like a sham surgery in animal research, but it's used as a contrast in group studies of drugs of different drug effects of different dosages. Interestingly, there's kind of a term that physicians are sometimes taught, and they're told to prescribe Obikelp to anxious patients to try to relax them. So they write a prescription for Obikelp, and they say, go get this filled from your pharmacist, and it will relax you. Anybody know what Obikelp is?
Some kind of placebo?
What's that?
Some kind of placebo?
It's placebo spelled backwards. So the placebo effect is an interesting effect and very worthy of study. All right, so turning to some sites of drug action, drugs affecting behavior do so by affecting synaptic transmission. And agonists facilitate postsynaptic effects, and antagonists block or inhibit the postsynaptic effects. So this is an important concept that you should walk away from this course knowing what is an agonist and what is an antagonist. Now, neurotransmitters, as I mentioned last time, can be excitatory or inhibitory, but the effect that the neurotransmitter substance has on the postsynaptic membrane is really not determined by the chemical itself. It's determined by the nature of the postsynaptic receptors that the chemical stimulates and what ion channels are opened or not opened by that substance. So acetylcholine, as we talked about last time, has an excitatory effect on membranes of skeletal muscle fibers, but it has an inhibitory effect on cardiac muscle fibers. So that's because acetylcholine receptors on skeletal muscle control sodium channels and produce depolarizations or excitations, whereas acetylcholine receptors on cardiac muscles control potassium ion channels and they produce hyperpolarizations or inhibition. The major sites of drug action I've tried to break down into these four major categories, and these are basically how drugs work. The drug can affect production of neurotransmitters, either stimulating the production or inhibiting the effects. It can cause effects on the storage and release of neurotransmitters. It can promote the release of neurotransmitters, or it can make it less likely that neurotransmitters are released or interfere with the storage. It can produce effects on receptors in several different ways. On the postsynaptic membrane, we can have the drug act as a direct antagonist, mimicking the effect of a neurotransmitter, or the drug can be a receptor blocker or a direct antagonist, where it prevents the neurotransmitter from opening the ion channel. On the presynaptic, still on the postsynaptic membrane, we have multiple binding sites or non-competitive binding, where a drug can potentially bind to an alternative receptor site and produce the same action as a neurotransmitter, rather than the competing for the one neurotransmitter's binding site itself. And then on the presynaptic membrane, we have presynaptic heteroreceptors and autoreceptors that regulate the amount of neurotransmitter that is released. And drugs can either stimulate the presynaptic heteroreceptors that would change the likelihood that an ion channel is opened, and the same thing can happen if the drug stimulates autoreceptors on the presynaptic membrane to change the amount of neurotransmitter that's ultimately released. And then finally, the drug can actually have an effect on reuptake or destruction of neurotransmitters, either preventing the reuptake so that the drug or the neurotransmitter can stay around longer, or it can destroy the enzyme, or it can destroy the neurotransmitter itself, and kind of eliminating its effect from the synapse. This is just an example of a direct agonist and a direct antagonist, and this is where the neurotransmitter normally binds. The drug can bind to that very site as well and mimic the effect of that neurotransmitter. That would be a direct agonist, and if it opens the ion channel, and if it does the same thing and it prevents the ion channel from opening, it would be a direct antagonist. So in this case, a drug is kind of competing for the binding site of the neurotransmitter. There's only one such binding site. Other neurotransmitters can bind to their normal site, and a drug can bind to an alternative binding site itself. And in this case, this would be an example of non-competitive binding. Here, when the drug binds to this alternative site, it can also act as, in the same way, if it opens the ion channel, act as an indirect agonist. Again, indirect referring to that non-competitive binding. Whereas over here with the drug binding to the alternative site, mimicking the effect of the neurotransmitter, keeping the ion channel closed, it would be an indirect antagonist. And this is an example of presynaptic heteroreceptors where here we have a presynaptic terminal button that would be releasing neurotransmitter into the synaptic cleft to stimulate this postsynaptic terminal button. And these are presynaptic heteroreceptors that are sensitive, that can, I guess, be affected by the drug that, if present in the synaptic cleft, it would inhibit the likelihood of the calcium channels, in this case, opening or closing. And so if the opening of the calcium channels is inhibited, we have what's known as presynaptic inhibition, and if the opening of the ion channels is facilitated by the drug, then we have what's called presynaptic facilitation. This is a diagram from your textbook, and it kind of shows the major sites of drug action. And the first two, we have the drug serving as a precursor for a neurotransmitter. In the example of L-DOPA being converted to dopamine via dopamine beta hydroxylase, that drug would act as an agonist. It would produce more of the dopamine, causing more of it to be available. For treatment of Parkinson's disease, we have to give Parkinson's patients L-DOPA rather than dopamine itself because dopamine can't cross the blood-brain barrier. The L-DOPA can be taken into the body, and then when it's converted with this enzyme, dopamine beta hydroxylase, it converts it in the brain into dopamine. So in that case, L-DOPA is serving as an agonist for dopamine. The drug can actually inactivate a synthetic enzyme and therefore inhibit the synthesis of the neurotransmitter. So PCPA will actually block the enzyme tryptophan hydroxylase that converts tryptophan into, or 5-HTP into serotonin. So by inhibiting that, the synthesis of that neurotransmitter, by blocking that enzyme, that drug is serving as an antagonist for serotonin. Along the side, 3, 4, and 5, we have factors affecting the storage and the release of the neurotransmitter. So in the case of reserpine, it makes the synaptic vesicles leaky. The synaptic vesicles that contain various monoamines like norepinephrine. So by making these vesicles leaky, making it difficult to store the monoamine, this would be an antagonist. So they would be less available because they need to be packaged into the synaptic vesicle to carry out their action. The drug can stimulate the release of neurotransmitter. In that case, it would act as an agonist. And black widow spider venom produces or stimulates the release of acetylcholine. So that would be a acetylcholinergic agonist. The drug could inhibit the release of the neurotransmitter, like botulinum toxin, sort of acts like black widow spider venom in reverse. It again inhibits the release of acetylcholine rather than stimulates it. And then number 6, the drug can stimulate the postsynaptic receptors themselves, acting as an agonist. So we know that nicotine and muscarine will stimulate certain of the acetylcholinergic receptors. The acetylcholinergic, the nicotinic receptor is stimulated by nicotine. That's how it got its name, in addition to acetylcholine. And same thing with muscarine. Number 7, the drug can block postsynaptic receptors, acting as a receptor blocker. And so in this case, it would be an antagonist. So the drug curare or atropine even would block the acetylcholinergic receptors so that acetylcholine couldn't exert its effect anymore. So moving over to this side, we have the drug-stimulating autoreceptors inhibiting synthesis and release of the neurotransmitter. So apomorphine stimulates dopamine receptors, and particularly the autoreceptors. Therefore, in this case, as it's stimulating the dopamine receptors, it's reducing the release of dopamine and therefore acting as an antagonist. Number 9, the drug blocks autoreceptors and increases the synthesis and the release of neurotransmitters. So if we're blocking the autoreceptors, then we're letting much more neurotransmitter flow out, and that we would see with a drug called isodoxin stimulating the production of or release of norepinephrine. Isodoxin was actually being used as an antidepressant, but it actually had some side effects that weren't acceptable. So, but it would have been an agonist for norepinephrine. And finally, the drug can block reuptake of the drug. So cocaine and amphetamine both block the reuptake of dopamine, so dopamine stays around longer. We all know that dopamine is sort of the pleasure chemical, or we get a little squirt of dopamine every time we win at gambling, for example, or we get reinforced for something, there's a little extra squirt of dopamine. But cocaine and amphetamine block the reuptake, so that dopamine is staying around longer.
So this makes me wonder, how come amphetamine and cocaine are drugs are abused by something like L-Dopa, which also breaks down dopamine in the brain, that is, as far as I'm aware, does not have abuse potential. People don't do it recreationally.
Right. No, people wouldn't want to do it recreationally because too much dopamine would produce hallucinations and schizophrenia. When we talk about the dopamine story, we'll see that there's a continuum where there's too little dopamine that's associated with Parkinson's disease, too much dopamine, we have schizophrenia and hallucinations. So, I think that in that case, it would be stimulating also a different region. We'll see that there's 3 different dopaminergic systems, only one of which is really involved in that major pleasure type of system. Then I've also alluded to the inactivation of acetylcholinesterase by certain anti-Alzheimer's drugs. And so iproniazide also inactivates monoamine oxidase. Monoamine oxidase breaks down some of the monoamines like norepinephrine. Iproniazide actually was used to treat tuberculosis, but it was found to have some antidepressant qualities, and so it was used as an antidepressant for a while. But it's a monoamine oxidase inhibitor, which has some potential side effects. All right, so why don't we take a break there, and we'll take 5 and come back, and we'll finish up with talking about the neurotransmitter systems and then get into research techniques.
Yeah, I have a question.
Sure.
Placebo.
Mm-hmm.
So it would be incorrect to say that like people who give placebos and it works on them, would it be incorrect to say that they're faking it? Like
Yeah, they're not faking it. They really
believe
yeah.
it.
Yeah.
So could you say like it's not real because placebo is working? So like whatever they're thinking is not like real. Is that a better way to say it? I don't want to say faking because they believe it, but it's not actually there, right?
Well, it's actually there because they demonstrate an effect. Their blood pressure can go down.
The minor and stuff like that. But like, okay.
So it's
So is it
sort of defies explanation in a lot of ways.
So okay. So is it like illegal for like for doctors to prescribe that first if they believe?
No.
Because you're paying for it technically. Like your
Well, they might
pharmacies
have no
everything.
copay when they get it.
Yeah,
so.
that's true. So I don't know. It's really interesting. Like I hope people can doctors can prescribe that more at first, just to see if it works instead of like going with the hard stuff first. So. Okay, that's interesting. So it's real, but it's confusing.
It's real effects. Yeah.
Okay. Thank you.
You bet. Hi, Mesa. That's all right. Yeah.
And I don't know if we ever spoke about you needing any students for volunteering for research.
Yeah, right now my student from last semester decided to continue on.
Okay.
So unfortunately I don't have any openings this semester.
Maybe in the fall?
Maybe,
Okay.
yeah. Yep.
All right, sounds good.
Okay, that makes sense. Yeah, that makes sense.
Yeah. No.
Does placebo effect work with like acne treatments too?
With acne treatments? That's a really good question. I don't know of any studies that have looked at that, but that would be cool to kind of look up.
Yeah, I've heard like random herbal remedies and stuff. Like, I'm sure half of it isn't real, but like, I really believe it works, but I know a lot of stuff.
Yeah. Well, herbs were the first drugs, and aspirin is derived from, plants. So I think like essential oils or things like that nature, do have a biologically active.
They're not creative in those states.
Yeah.
It works for kids.
Yeah.
My daughter is constantly getting for medication. She wants
I think they're
Uh huh.
I work in a pharmacy.
Uh huh. Oh, the placebo effect right there. Placebo effect right there. Cool.
I know that people break them and like just kind of like balls and
All right, let's go ahead and get back to it. Was there anybody who came in after I started class and didn't check in? Prince, yeah, I got you. I got you, Mason. All right, at this point I wanted to start talking about some of the different neurotransmitter systems. And I'll start off with acetylcholine because that's the primary neurotransmitter that's secreted by efferent axons of the central nervous system. You know, efferent axons are the ones that are producing the movement. All muscular movement is accomplished by acetylcholine release. And acetylcholine, as we know, is found in the sympathetic and the parasympathetic nervous system. It's found in the preganglionic fibers of the sympathetic nervous system and in both the pre- and postganglionic targets of parasympathetic nervous system. Acetylcholine is made up of choline and acetate, and there's an enzyme called choline acetyltransferase. And acetyl-CoA transfers acetate to choline via that enzyme. This is how it happens. This is our choline acetyltransferase molecule, and it links up a molecule of choline and acetyl-CoA or coenzyme A here. And so then liberates the CoA and produces the acetylcholine. And here is just the transfer of acetate ions being sort of, or choline ions or molecules being taken back up into the cell via a choline transporter. There's actually a special channel that allows choline to be taken back up. That choline transporter can actually be inactivated by a compound called hemicolinium. And so if that happened, then no more choline would be able to re-enter the cell and be recycled. The acetylcholinesterase down here is what deactivates acetylcholine. And again, it separates the acetate ion and the choline molecule. So the distribution of acetylcholinergic neurons is presented here. And we see that the locus ceruleus is the origin of many acetylcholinergic neurons. We'll also see that this locus ceruleus region is a major player in the origin of noradrenergic neurons. We also have another nucleus called the nucleus basalis that is in the basal forebrain. And that sends projections, acetylcholinergic projections, forward into the frontal cortex. And then we have another area of acetylcholinergic neurons in the medial septum. And then, again, you can see that there's a lot of distribution into the neocortex, frontal cortex, down into the hypothalamus and amygdala, and from the locus ceruleus into a lot of the other surrounding subcortical structure. We have two different types of acetylcholinergic receptors, the ionotropic nicotinic receptor that's stimulated by nicotine, and the metabotropic receptor that's stimulated by muscarine. The muscarinic receptor's actions are slower and more prolonged than for the nicotinic receptor because they're relying on the second messenger system for their opening and closing of ion channels to take place, whereas the nicotinic ionotropic receptors will open and close the ion channels much more quickly or much more directly. There are more muscarinic receptors in the central nervous system and more nicotinic receptors in the peripheral nervous system and skeletal muscle. The effects of acetylcholine are usually facilitatory or activating or excitatory. If neurons in the dorsolateral pons are stimulated, for example, it can elicit characteristics of rapid eye movement sleep or REM sleep. And stimulating neurons in the basal forebrain will activate the cortex and facilitate learning, especially perceptual learning. And stimulating the neurons in the medial septum controls electrical rhythms of the hippocampus. So again, all of these activation of these acetylcholinergic neurons through stimulation will produce more of a facilitatory, activating, or excitatory type of effect. The monoamines are kind of a broad class of compounds, and we can divide those up into the catecholamines. And there are three major types: dopamine, norepinephrine, and epinephrine. And the indolamines, the most prominent of which is serotonin, or 5-HT, and histamine kind of rounds out the amines. So those five compounds are examples of monoamines. Here, monoamine oxidase regulates the production of catecholamines in general. It destroys excessive amounts of neurotransmitter. Monoamine oxidase acts very much like acetylcholinesterase for breaking down monoamines. Deprenyl is a drug that destroys MAO-B, or MAO type B, in dopaminergic terminal buttons, and so deprenyl is often administered to reduce dopaminergic neuron destruction by Parkinson's disease. The MAO, monoamine oxidase, in our blood actually deactivates certain amines in mostly stinky cheeses and chocolate and some red wines, and that's really important because it keeps those amines from boosting our blood pressure to dangerous levels. People who are taking monoamine oxidase inhibitors for depression, for example, would sometimes be at risk for the drug producing this side effect. The monoamine oxidase in our blood would no longer deactivate those amines in stinky cheese and chocolate, and oftentimes they have problems with high blood pressure, dangerously high blood pressure, and other related side effects. And this is just a synthetic pathway going from tyrosine to dopamine and norepinephrine, and dopamine beta hydroxylase can convert dopamine into norepinephrine. Tryptophan is an amino acid, and that can be converted into 5-hydroxytryptophan, or 5-HTP, with tryptophan hydroxylase, and then 5-HTP decarboxylase is the enzyme that converts 5-HTP to 5-HT. So taking dopamine first, dopamine can produce both excitatory and inhibitory postsynaptic potentials. Depending on the postsynaptic receptor, it's involved in movement, attention, and learning. There are several major systems of dopaminergic neurons that I mentioned a little bit ago. And the three most important systems arise in the substantia nigra and the ventral tegmental area. So we have the nigrostriatal system. Now again, the naming convention is nice because the first part of the name tells you the origin, where the neurons start, and the second part of the name tells you where the neurons project to or end up. So the nigrostriatal system projects from the substantia nigra to the striatum, which is or neostriatum, which consists of the caudate nucleus and the putamen, both major players in the basal ganglia. And the nigrostriatal system is mostly involved in movement. And it's really those dopaminergic neurons that are affected in Parkinson's disease. The mesolimbic system is located in the ventral tegmental area, not the substantia nigra, and then projects to the limbic system, particularly the nucleus accumbens, which is the reward center, as well as the amygdala and the hippocampus. The mesolimbic system is sort of what goes awry with addictions and things like that. That's where a little squirt of dopamine happens. And the mesocortical system is also located in the ventral tegmental area, but it projects instead of the limbic system, it projects to the prefrontal cortex. So it exerts more of an excitatory effect on the frontal cortex and affects short-term memory formation, planning, strategy preparation, and things of that nature. And this is an example of the nigrostriatal system that originates in the substantia nigra and projects to the globus pallidus, caudate nucleus, and putamen, so the basal ganglia involved in movement. Then we have the ventral tegmental area that gives rise to the more of the mesolimbic system, amygdala, thalamus, habenula, which is involved in reinforcement, nucleus accumbens, and then we have the mesostriatal system that goes into the frontal cortex that I talked about. So those are kind of the four, or the three systems of dopaminergic neurons. L-DOPA is often given to patients with Parkinson's disease, as I mentioned, to stimulate dopamine production because dopamine can't cross the blood-brain barrier. Alpha-methyl paratyrosine is a drug that inactivates tyrosine hydroxylase. If tyrosine hydroxylase is inactivated, then that would limit the production of catecholamines from tyrosine itself. And reserpine is an antihypertensive agent and not really used much anymore, but it makes the synaptic vesicles leaky, as I talked about before. In that case, it would be a monoamine antagonist because it negatively affects the storage of the catecholamines. There are 5 different dopamine receptor types. All of the dopamine receptors are metabotropic. D1 and D5 receptors are exclusively postsynaptic, and stimulation increases cyclic AMP, that second messenger. The D2 receptors are both pre- and postsynaptic. Here, stimulation decreases cyclic AMP production, and D3 and D4 receptor stimulation also decreases cyclic AMP, or second messenger production. Apomorphine is a D2 agonist. It binds specifically or preferentially to those D2 receptors, but it prefers the presynaptic D2 receptors in particular. Cocaine and methylphenidate, or Ritalin, used for attention deficit disorder, are both blockers of dopamine reuptake, just like amphetamine. And so cocaine also blocks voltage-dependent sodium channels from opening as well. So cocaine has not only an effect on dopamine reuptake, but it also blocks the sodium channels as well. Excess dopamine, as I mentioned before, is sort of at the other extreme associated with schizophrenia, and a drug called chlorpromazine blocks D2 receptors specifically, and usually too little dopamine is associated with Parkinson's disease. Yeah?
Are they doing more and more brain scans to be able to tell that there is actually more, dopamine going through the brain, like how you said for depression?
Oh yeah, there's
I know that psychiatrists do not do CAT scans or any kind of scans. They just observe and then they write a script.
Yeah, some do, but oftentimes they don't. To look at that, but I think they were more likely to treat the symptoms of schizophrenia as opposed to kind of measuring levels of dopamine and things like that. But studies using a particular type of imaging called PET, or positron emission tomography, have actually they can put a radioactive label on a cocaine molecule or chlorpromazine or dopamine molecule, and they can actually look at the receptor distribution in the brain and how much of the chemical is bound to the receptor. So there are ways of imaging the effect of different neurotransmitters. There's an interesting story, the MPTP story. There was a few people out in California who were drug abusers, and they had gotten a hold of a substance that was a so-called designer drug. Drugs are made illegal by virtue of their chemical structure. That's how they're defined as being illegal. And so, if you put a methyl group or something on one end of a molecule, hopefully you don't change the biological activity of it, but then all of a sudden, because it doesn't conform to any of the illegal drug structures, it's not. You can't be arrested for it. Unfortunately, this group of people got this bad batch of this synthetic heroin that immediately changed them into Parkinson's patients. And the substance was MPTP. And what happened is this MPTP, when it was injected, was converted to this form of MPP+, this molecule called MPP+, by monoamine oxidase. And then the MPP plus accumulated in the mitochondria and blocked the mitochondria's ability to metabolize the nutrients. And so instantly the people were made into Parkinson's patients. Remarkably, they were able to be treated with anti-Parkinson's medication like L-Dopa. It restored their ability to move for a period of time. Some of them went on to have other surgeries for Parkinson's disease, putting a lesion in the globus pallidus, for example, or having deep brain stimulation. But unfortunately, those techniques were only temporarily effective. So again, they had same features exactly as Parkinson's disease. Ann?
Why was their result so permanent? Since they took heroin, why didn't it wear off or something?
Yeah, this was a very toxic form of a very toxic chemical that accumulated, and it basically killed the mitochondria and the neurons. And once the mitochondria die, the cells can't support themselves anymore. They have no more way of staying alive. So, and that's it sort of is a model for how Parkinson's disease happens. I know primates are sometimes subjected to MPTP to produce Parkinson's disease as a way of studying how to treat it. But that's created now an animal model for Parkinson's disease. Norepinephrine, noradrenergic neurons are located in the pons, the medulla, and in one region of the thalamus. And this, as I mentioned before, the cell bodies and the most important noradrenergic systems start in the locus ceruleus. There's several types of receptors. We have beta 1 and 2 receptors and alpha 1 and 2 receptors. So 4 receptor types. Again, locus ceruleus is the major player there. Adrenaline and epinephrine are synonymous, and noradrenaline and norepinephrine are synonymous. Between adrenaline and noradrenaline is the more important neurotransmitter. Dopamine can be converted to norepinephrine through the action of dopamine beta hydroxylase, as I showed you on a previous slide. There's a drug called fusaric acid that can inhibit that enzyme, and so that would block norepinephrine production without affecting dopamine production. So it would just prevent the conversion of dopamine to norepinephrine by blocking this compound. So that's again one way to make more dopamine stay around, but unfortunately less of it can be converted to norepinephrine. Meclobamide blocks the monoamine oxidase A enzyme. MAO-A destroys excess norepinephrine in the terminal buttons. Most of the neuroadrenergic neurons, though, that release norepinephrine don't do so through terminal buttons. Noradrenergic neurons have this interesting or curious feature where they're released through axonal varicosities, which are bead-like swellings of axonal branches. So it's important to kind of keep in mind these noradrenergic neurons are more associated with the axonal varicosities as opposed to the terminal buttons that dopamine and acetylcholine, for example, would use. Adrenergic receptors can have both excitatory and inhibitory effects, just like dopamine. In general, the behavioral effects are excitatory. You stimulate adrenergic receptors, you get more excitation. But the alpha-1 receptors produce more of a slow depolarizing excitatory effect, and alpha-2 receptors show a slow hyperpolarization. Those alpha-2 receptors are actually involved in sexual behavior and appetite control. The beta receptors, beta 1 and beta 2, both increase the responsiveness of the postsynaptic neuron to excitatory stimulation. So you can see here the noradrenergic neurons originate in the locus ceruleus and project throughout the brain into the thalamus, basal ganglia, frontal cortex, olfactory bulb, preoptic area, and so forth. The preoptic area projections are located or associated, and hypothalamus are associated with sexual behavior, and you see it's also projecting to the thalamus as well. Serotonin, sometimes called 5-HT for 5-hydroxytryptamine, plays a role in a lot of different things, both sleep, arousal, both sexual arousal and being awake, mood regulation, appetite, pain regulation, and dreaming. 5-HT is also released from varicosities, just like norepinephrine, rather than terminal buttons. And the two most important clusters of the serotonergic cell bodies are in the dorsal and the medial raphe nuclei. And here are the raphe nuclei here, and there's one midline and two lateral ones. And again, they're very close to the substantia nigra, but when you think of the raphe nuclei, you think of serotonin. You can see that the raphe nuclei send projections all throughout the brain. There are 9 different types of serotonin receptors. Only the 5-HT3 receptor is ionotropic. It actually controls a calcium channel. The 5-HT3 receptor plays a role in nausea and vomiting. I think the drug called ondansetron is used it binds to that receptor. The reuptake inhibitors, serotonin reuptake inhibitors that I mentioned before, fluoxetine or Prozac as an example, or Zoloft, sertraline. Fenfluramine is also a reuptake inhibitor, and that's used as an appetite suppressant. LSD is a direct agonist for postsynaptic 5-HT2A receptors in the forebrain. So when LSD binds to that receptor, it causes the hallucinatory effects. MDMA, or ecstasy, is both a noradrenergic and a serotonergic agonist, and it has both excitatory and hallucinogenic effects. It actually causes the noradrenergic transporters to run backwards, causing norepinephrine release and then inhibition of its reuptake. So there's this massive flood of norepinephrine into the synaptic cleft. And so because it's got so much stimulatory activity or so much release of the norepinephrine, MDMA can damage serotonergic neurons as well as noradrenergic neurons and cause cognitive deficits. So it's a very, very dangerous drug. We have a couple of amino acids that serve as major neurotransmitters, and the first amino acid is glutamate. Glutamate is the principal or main excitatory neurotransmitter in the central nervous system. And there's no real effective way to prevent its synthesis. There haven't been any good drugs that they've come up with to prevent its synthesis without disrupting cellular function altogether. There are 4 major types of glutamate receptors. There's the NMDA receptor, which we'll talk about in more detail, the AMPA receptor, the kainate receptor, and all 3 of those are ionotropic, and then the glutamate receptor, or glutamate, is metabotropic. The AMPA receptor is most common of the 4 neurotransmitters throughout the brain. And the NMDA receptor has actually 6 different binding sites. 4 are on the outside and 2 are on the inside. And the NMDA receptor is interesting because it allows both calcium and sodium to enter the cell when it's open, causing depolarization. As the inside of the cell now gets more positive, making it more likely for depolarization to happen. Calcium that enters the cell also binds to various enzymes and activates enzymes, and so that calcium entry can actually serve as a second messenger. And so that allows or alters synaptic characteristics that provide some of the building blocks of newly formed memories. The NMDA receptor, as we'll see in at least a couple of weeks, is very intimately related to the memory system. This is an up-close and personal view of the NMDA receptor. And what's cool about the NMDA receptor is that it's both voltage-dependent and neurotransmitter dependent. So if glutamate binds to that NMDA receptor, nothing will necessarily happen unless the cell has been partially depolarized. And the reason for that is because there's a big old magnesium ion that blocks that channel. So here glutamate binds to its receptor and nothing happens necessarily because that magnesium is still plugging up the works. But if the membrane is partially depolarized, then that will displace the magnesium from its space here, and then that will open up the channel and allow calcium to enter. So the NMDA receptor only opens if glutamate binds to it and the membrane is partially depolarized. Let's say the membrane is partially depolarized, then it's still not going. The channel is still not going to open because the glutamate hasn't bound to it to start that opening process to occur. Alcohol is an NMDA receptor antagonist, so it keeps the NMDA receptors closed. And PCP is an indirect NMDA receptor antagonist and also prevents calcium from entering the cell. GABA, or gamma-aminobutyric acid, is an inhibitory transmitter with widespread distribution in the central nervous system. It's probably the principal inhibitory neurotransmitter in the central nervous system. So very important to know that GABA is inhibitory and glutamate is excitatory. There are 2 receptors, 2 GABA receptors, GABA-A, which is ionotropic and controls a calcium channel, and GABA-B, which is metabotropic and controls a potassium channel. There are multiple binding sites, or at least 5 of them, at both GABA-A receptors, and benzodiazepines or anxiolytics bind to GABA-A receptor sites. This is an up-close and personal of the GABA receptor. These are all the different receptor sites on the receptor. There's a specific benzodiazepine site, a steroid site, the GABA site itself for the neurotransmitter. There's a picrotoxin site over here, and a barbiturate and alcohol site. Glycine is the third of the 3 main amino acid neurotransmitters, and that's the inhibitory neurotransmitter that's found in the spinal cord and then the lower portions of the brain stem. The glycine receptor is ionotropic and controls the chloride channel. The bacteria that produce tetanus actually release a chemical that prevents the release of both GABA and glycine, promoting a continuous state of muscular contraction. And strychnine is a glycine antagonist. There have not been any glycine agonists that have been found, though. Peptides. There are a lot of peptide neurotransmitters. Peptides are released from all parts of the terminal button, and most of those peptides serve as neuromodulators, but some act as neurotransmitters. Some of the neuromodulators that are important that we've seen are the endogenous opioids, or endorphins. These are the compounds that are produced by the body that are just like, very similar to in chemical structure, heroin and the morphine and things like that. And they produce the so-called runner's high. Enkephalins are closely related to the endogenous, or the endorphins. There's a metenkephalin and a leuenkephalin. Those two are the only two members of a family of endogenous opioids, which are all synthesized from one of three larger peptide precursors. Naloxone, the drug that a lot of people carry now because of the opioid epidemic to reverse opioid intoxication, is a direct antagonist, and so it would kind of bind to the opioid receptors, sort of kicking off the opioids themselves. Heroin, Percodan, and drugs of that nature are direct agonists by binding to the receptor sites for the endogenous opioid system. Three different systems for these endogenous opioid peptide neurotransmitters exist. One produces analgesia and is probably the best known. Another one involves inhibition of the species-typical defensive response, like fleeing and hiding. And a third system is associated with reinforcement. Lipids. The endocannabinoids are probably the best known lipid neurotransmitter. We know about that the active compound of marijuana is THC, or tetrahydrocannabinol, and THC stimulates the cannabinoid receptors in our brain in specific regions. There's two types, CB1 and CB2. And generally when they're stimulated, they produce analgesia and sedation. Stimulation of CB1 and CB2 receptors also stimulates the appetite, and it reduces the nausea that is sometimes induced by chemotherapy drugs, decreases intraocular pressure in glaucoma patients, and reduces symptoms of certain motor disorders. It also, though, interferes with memory and concentration. It alters visual and auditory perception and distorts perception of passage of time. And also when, in some people, it can be associated with the development of a psychotic episode. Even the first use of marijuana, for example, can produce a psychotic episode in some people. Acetaminophen in particular, or Tylenol, acts on CB1 receptors, and it's partially through that mechanism that it reduces pain. So we know that the CB1 receptors are definitely associated with pain and analgesia, and we don't really know the mechanism of action at this point of CBD oil that's derived from the marijuana plant, but it doesn't have the THC in it. But I would be willing to bet that it stimulates a CB1 receptor to produce the analgesia.
You see that girl that her parents fought to get her to take the CBD because it was against the state law, and then she went from 100 seizures a week to like 3.
Wow. Yeah, it can have some really dramatic effects.
So she got a lot better quickly.
Yeah, yeah. And it's legal now, so hopefully she'll be able to profit from that.
Yeah.
Other neurotransmitters exist as well. Nucleosides, which contain a sugar molecule bound with a purine or a pyrimidine base. Caffeine, in addition to being a phosphodiesterase inhibitor, blocks adenosine receptors to produce part of its action on wakefulness. And soluble gases, nitric oxide and carbon monoxide too, both of those serve as messengers in many parts of the body. I think some of these neurotransmitters are relatively poorly understood, certainly much less so than the major ones of acetylcholine, noradrenaline, norepinephrine, and dopamine and serotonin. All right, so any questions up to this point? Yes?
I was always learning about the nitric oxide. Do we know about how it's used in communication? Like, would it spread all over the brain when it's released, or is it kind of local? It's difficult to imagine the gas being
Yeah, it exerts its effects very locally, is my understanding of it. But that, and carbon monoxide too also serves as a neurotransmitter in much the same way. CO, NO. All right, at this point I wanted to jump into some of the major research techniques, and I meant to say 5 major research techniques here, but I've put 6. There are 5 that I've listed. We've talked a lot about lesion studies and kind of using strokes, for example, or brain tumors and their effect on behavior to try to understand how behavior is affected by loss of tissue in that in various areas of the brain. So I won't really go into those too much, but I did want to talk about recording and stimulation techniques. I should have added imaging techniques too, so maybe there are 6. But behavioral analysis and genetic methods and neuropsychological testing. And we'll definitely not get to the last 2 today. But in terms of recording the brain's electrical activity, there are generally 3 techniques for electrical recording. One of those is the single cell recording, trying to put an electrode into a single neuron to record its activity. Then the electroencephalograph recording and the event-related potential recording. So the single cell recording involves the insertion of the electrode into the brain adjacent to a neuron and then recording that neuron's activity. It's more commonly done with animals, but as many as 2,000 individual neurons can actually be recorded simultaneously. You can record either a single action potential or multiple action potentials with this technique, but it's a little bit difficult to kind of generalize from a single action potential to an experience of something to kind of understand how the activity of that neuron plays a role in our overall experience. This is an example of where the electrode would be placed in a particular region of the brain, and a little kind of a connecting socket placed on the outside and some dental plastic put around the outside of the incision. Unit recording is closely related. It monitors changes in a single cell's activity or electrical potentials. And sometimes the cell's firing is played through a loudspeaker, and you can hear the cells firing as little crackles or beeps or pops. And oftentimes neurologists or neurosurgeons use this to localize an electrode when they're doing a surgery on a particular part of the brain. They know that they're in the part of the brain they want to be in when they hear a particular firing pattern of cells from that electrode. And each cell has a preferred stimulus and a preferred response pattern, which is interesting. So some cells will only respond to whenever diagonal lines are presented, and some cells will respond only when white versus black stimuli are presented. Some cells will respond only to vertical movement and things like that. So each cell responds to or attends to a discrete, minute portion of the world or its receptive field. Any activity that the cell is designed to detect within its receptive field will cause that cell to fire, and you can record those firings through that unit recording. So this would be a single action potential occurring in 1 millisecond. This is 2 action potentials occurring in 3 milliseconds. and we have the occurrence of many action potentials in a 40 millisecond period that kind of reveal a change in firing rate, and that change in firing rate over time, that according to the rate law that we talked about last time, would indicate a changing pattern of brain activity. The EEG recording was discovered by Hans Berger back in the 1930s. EEG records electrical potentials or brain waves in the brain. There's presumably a signal generator which reflects the neurons that produce the rhythmic signal that we're observing on these electrical potentials in the brain. EEGs, you'll see, mostly are used for sleep studies, and in that context they're called polysomnography, or PSM, and then they can also be used to monitor the depth of anesthesia and by the production of slow waves that are produced as anesthesia goes deeper and deeper. They can also be used to study normal brain function. They also are used to screen for epilepsy, to look at possible what are called epileptiform discharges, or a spike and wave discharge, which would be reflected by a big uptick and then a kind of a slow wave after that big uptick. There's a spike and then a slow wave that follows it. That would be associated with epilepsy. And we attach electrodes to the skull corresponding to specific areas of the brain, and they're located by very precise measurements, and they have certain names associated with them, and then each pen is reflecting activity from one of those particular brain regions. And the polygraph electrodes are connected to little magnets that are connected to pens that produce a paper record of the electrical activity in the brain. Now it doesn't really even have to be a paper record. It can be an electronic record or digital record that can be saved forever. The EEG is mostly a measure of the dendrite's graded potential. So when we're measuring what produces the EEG, it's the dendrite's graded potentials mostly, but it also includes all neural activity, including action potentials. As I mentioned, it can be used to track the severity of head injury, anesthesia, brain trauma, and if there's a flat line, that's suggestive of brain death. There are several EEG patterns at rest. Normally, when we're awake, we're in what's called a beta state, and our brain waves would be going at about 20 to 25 cycles per second in the precentral and postcentral sensory motor area for the most part, but kind of throughout the brain. That would signal that we're alert and awake, conscious. Then as we get a little bit more relaxed, we have alpha waves that are about 8 to 12 cycles per second, more dominant in the posterior cortex. We see that start to come in when we close our eyes and we start to relax a little bit. Theta waves are 17 to 20 cycles per second in the secondary frontal area, which is associated with drowsiness, and delta waves are 8 to 12 cycles per second in the tertiary frontal area. Delta waves are more associated with deep sleep. Question?
Is there anything known about the functional significance of these different patterns, like what exactly the brain is doing and why it's happening, for what end?
Yes, it's more corresponding to general behavioral states here, but when we talk about sleep, we'll talk about the transition between each of these states. So this is an example of the kind of the high frequency, low amplitude beta waves. Then when we're producing more alpha waves, we have kind of a higher, a lower frequency, higher amplitude wave as our brain waves start to slow a bit. When we get drowsy, brain waves slow even more. When we're asleep, we can kind of see these very slow waves, a little bit of activity here and there. Deep sleep is even slower and higher amplitude waves. This would be somebody who's in a coma where the brain waves are very, very high amplitude and very low frequency. So when EEG, or when desynchronization occurs, that's the beta waves, desynchrony, low voltage, fast activity, that would signal the brain areas that are in active mode or very much activity. And then, as a rule of thumb, inactive brain regions produce slow waves, and active brain waves produce fast waves or desynchrony. And the rhythms become slower in frequency, larger in amplitude as a person falls asleep, during coma, during anesthesia. And as I mentioned, EEG is useful in detecting areas of the brain that are malfunctioning. Those would be the regions that show those slow waves. I mentioned spike in wave activity and epilepsy, and slow waves in a behaviorally alert person may indicate brain injury. And then again, just an example of the different locations of specific electrodes in the brain and their different patterns of activity. Event-related potentials make use of the EEG signal, but in this case, there's a brief change in a slow wave EEG signal in response to a discrete sensory stimulus. A stimulus, like a very simple stimulus, like a tone of a particular frequency, is presented repeatedly, and then the recorded responses on the EEG are averaged. And there's this technique called the auditory oddball, where there's a tone, a low frequency tone, that is played continuously. Boop, 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 boop. That oddball occurs only occasionally, but your brain would respond to that with a characteristic pattern. And basically the first response to that might look something like that. The first tone, the average of 10 tones might look something like that. And if we average 100 tones, now we start to see a wave that has a very characteristic component. The P1 component is the first positive component. The N1 component is the first negative component, getting more negative. P2 is the second positive component, and so forth. And these different wave components are labeled as P1, P2, P3, N1, N2, N3. And these can be used to produce kind of cool maps of cortical function, and different groups of neurons respond to the stimulus producing positive and negative waves. They basically are extracting the stimulus and response neural activity from an ongoing EEG in the millisecond to second range, so their temporal sensitivity, or their sensitivity to temporal brain functioning, or the time course of brain functioning, is quite good, but its ability to localize that brain function is not as good as like structural imaging techniques. It provides a good way to assess in real time changes in neural activity due to cognitive processing, but you have the limitation of having to place the scalp electrodes each time to record the electrical activity. This is again another example of an event-related brain potential where there's the stimulus onset, the time in milliseconds along the bottom, and the first positive component of the wave is the P100, occurs about 100 milliseconds after the stimulus. This is an N100, so sometimes they go by, the wave components actually go by the number of milliseconds following the stimulus onset, and whether the waveform was positive or negative. And this is just a diagram of the auditory oddball. The N0 to P1 components represent the early cortical components. P1 to N2 represent the late cortical components, and the dotted and the dashed lines are showing you the cognitive components that arise as the meaning of the stimulus is starting to be decoded. So is it the same stimulus as before, or is it different? That's kind of the meaning or the late cognitive processing component that emerges later on. There's also another technique that I should mention in the context of the event-related potentials. It's often confused with event-related potentials, but it's called evoked potentials. Evoked potentials deal with very simple sensory stimulation, like a click or a flash of light, for example. And the brain's response to the click and flash of light can give some insight into the functioning of neurons in particular critical areas. Sometimes evoked potentials are used to evaluate people who are possibly brain dead, to see whether their brain is still processing information. It can also be used to look at neuropathies, optic neuropathy in the case of multiple sclerosis, for example, or things of that nature. So we have kind of the event-related potentials, electroencephalogram event-related potentials, and the evoked potentials are very simple sensory stimuli. In addition to recording the brain's activity, we can stimulate different areas of the brain to see what it does and try to get some sense of what function that area of stimulation has. And usually electrical current is used to stimulate the brain tissue. We have things like deep brain stimulation that is an intracranial technique where electrodes are implanted in the brain directly to stimulate the tissue. Deep brain stimulation is one of the more successful surgical approaches for treatment of Parkinson's disease, and it helps to reduce this akinesia or dyskinesia or the absence or irregularity of movement. Parkinson's patients are frozen many times in the advanced stages, and so with deep brain stimulation it can actually help them move. Unfortunately, deep brain stimulation can also produce some changes in mood and cognition, and it can produce infection and irritation, but it represents many people's only way of trying to get out of their, or try to deal with their very significant disorder. Some of the early stimulation techniques started with taking a fine electrode and placing it in a predetermined site, and then putting low voltage pulses of current into the area to stimulate the tissue. Hess pioneered this work in animals, and Wilder Penfield was a famous neurosurgeon from Canada who, during epilepsy surgery, would stimulate various parts of the brain. We still use brain stimulation during epilepsy surgery. I did it all the time in epilepsy surgery, where we would try to map out areas of the brain that were associated with language. And so when the person was undergoing their surgery, they would be brought out of their anesthesia, and then I would do neuropsych testing with them while we were stimulating various parts of their brain, and I'm looking for various effects on the speech. So in that sense, it's very it can be used to kind of tell the neurosurgeon where to cut and what parts of the brain to leave and what parts of the brain to take. This is a human stereotaxic instrument that holds the brain in place, and it's used for placing needles in the brain for that deep stimulation or for recording. You might have heard of a technique called transcranial magnetic stimulation, or TMS. This is the stimulation of a brain using a magnetic stimulator, and it is a small wire coil in the shape of a figure 8. It's non-invasive, ostensibly. It can be used to map out functional areas of the brain, and it's been used for ways to try to treat movement disorders, try to treat depression, chronic pain. I was part of a group that published a study looking at its ability to treat depression. We didn't find any real benefit for its treatment of depression, but other people have. But it's a very interesting technique. We have this transcranial stimulator, magnetic stimulator that's placed, you can see it's sort of in the form of a figure 8. And it's placed over a region of cortex that you want to stimulate. And basically when it fires, it generates a very intense magnetic field in this form of the figure 8. Well, perpendicular to any magnetic field is an electrical field. And you can measure a magnetic field around the electrical wires in your cords in your house. There's a little magnetic field, always perpendicular to the electrical field. So electricity and magnetism go hand in hand. So that's basically how it works. It shoots basically an electrical pulse into the brain, but not really very deep. So I've actually had it done to myself when we were publishing a study on its effects on language, and basically put it over Broca's area, and you can become a Broca's aphasic for a short period of time. I would be counting 1, 2, 3, 4. So it's the thing that I don't like about it, though, is it hurts. It fires the muscles of your head, and the temporalis muscle is one of the largest in your head, and it produced a muscular contraction that I did not like. And even as I talk about it now, my palms start to sweat, and that was almost 20 years ago. So that's a magnetic stimulator, kind of about the size of it. Some of them might be a little bit smaller than that, but basically put it over the area that you want to target and let it go. It does have kind of a loud pop sound. It's a little disruptive. With brain stimulation techniques, it's important to keep in mind, I think, 3 different types of effects that the stimulation can have. It can produce a relatively discrete action, like a twitching in a specific area of the arm when the appropriate part of the motor cortex is stimulated. Or it can produce kind of an energizing effect or activational effect when the animal might display approach avoidance reactions, eating or sexual behavior. Can elicit abnormal electrographic effects on the brain tissue. It can actually produce a seizure or other behaviors. Kind of going back to the transcranial magnetic stimulator, I watched a video of a young lady who was having it done, and she kind of looked at her arm with a puzzled look, and then she had a full-blown seizure. So in some people it can produce seizures, and that's why it has to be used very, very carefully. I wanted to talk about some of the major neuroimaging techniques as well. We have really the CT or computer tomography scan or CAT scan and the MRI scan are the most used for neuroanatomic purposes. We have neurochemical detection, which is in the domain of PET, positron emission tomography. We can also use PET and a related technique called SPECT, or single photon emission computer tomography, or functional magnetic resonance imaging, fMRI, to look at brain utilization of energy resources. So we can look at areas of the brain that are have increased or decreased metabolism, or increased or decreased blood flow. Those are the domains of PET, SPECT, and fMRI. And then the electromagnetic types of neuroimaging would include the EEG, evoked potential, like I mentioned, event-related potential, and magnetoencephalography, which is also makes use of electromagnetic recording. The goals of human neuroimaging would be to try to examine the structure of the brain, look at the functional architecture of the brain during sensory, motor, and cognitive processing, look at neural dysfunction at both anatomic and functional levels in clinical populations, and to compare those with non-clinical populations, and also to look at the distribution of endogenous substances like receptors, neurotransmitters, the presence of neuropathology associated with Alzheimer's disease, for example, like amyloid and tau. And we have the technology now to actually gauge how much of these substances a given person has in their brain. Now, we've come a long way. X-rays were really the first way to sort of peer inside the body, and they were developed by Wilhelm Röntgen in 1895. And X-rays are still used in many cases, and we want to try to look for evidence of skull fracture, for example, in traumatic brain injury. So the plain old X-ray is still used and can be informative to a certain extent. Pneumoencephalography, or PEG, came along, and this is a kind of a barbaric sounding technique, but it was commonly, or fairly commonly used. What they would do is they would drain off the cerebrospinal fluid from the brain. They would take it out of through a lumbar puncture, and they would replace the cerebrospinal fluid with air. And because air has a different, I guess, a susceptibility to X-rays, or no susceptibility, it allowed people to actually see the brain tissue a little bit more clearly. So in this is an actual PEG, and you can actually see brain tissue. You can see some of the sulci and gyri, although it's not very defined at all. But nevertheless, you can see the brain there, but you can't really see much of the brain there. So this pneumoencephalography was done probably, I don't know, up until about the 1970s or so, and that kind of gave way to the CT scan. This image is of an angiography, cerebral angiography, and it's basically a contrast medium that's injected into the brain, and it fills up the blood vessels in the brain, and then an X-ray is taken. So this way we can actually visualize some of the vasculature. We always do one of these before we do a special test called a WADA test, where we actually put one hemisphere of the brain to sleep. That's it for evaluating whether somebody is a good surgical candidate for epilepsy surgery. We want to make sure that the vasculature of the brain is okay, because to do that technique, we inject a small amount of barbiturate that puts the brain to sleep. We don't want it to fill both hemispheres, because that would be bad. If it just fills one hemisphere, that's fine. So as I mentioned, the PEG sort of gave way to the computerized axial tomography, or the CAT scan, and we can actually get relatively good images of the brain with the CAT scan. It involves X-rays, but the X-rays are projected from many different angles. There's two cameras kind of that rotate around and take many, many pictures as they're rotating. And because we're taking the X-rays from many different angles, we're able to detect the very slight variations in the X-ray absorption by brain tissue. So we can visualize brain tissue. We can have a two-dimensional projection of a two-dimensional slice, so we can do those sagittal, coronal, and axial sections that we talked about last time. And we can have very high spatial resolution in order to look at very specific brain structures. But the disadvantages is that the radiation that you get is still kind of high. I wouldn't want to do this just as a research subject. And it doesn't really have any temporal resolution. It's only a static picture in time. It doesn't look at the brain processing over time or changes over time. But nevertheless, you can see the bony skull, and you can even sometimes make out some of the layers of the meninges. You can see the ventricles very clearly in the brain, and these little projections up here into the lateral ventricles are the caudate nuclei of the basal ganglia. And we can very clearly see brain lesions with a CT scan. That's a very clear lesion there in the frontal cortex, and invading a little bit into the temporal region. The magnetic resonance imaging, or MRI technique, actually is a little bit different approach, and it's uses actually a magnetic field and radio waves, doesn't involve radiation at all. So it is much safer than a CT scan in terms of exposure radiation. And turns out that hydrogen molecules are present in our brain in the form of water. And when we put a hydrogen molecule into a very strong magnet, the molecules all line up into the same orientation. And so we use then radio waves to excite those molecules to knock them over, basically. And we measure the energy that they take to move back to their orientation within the magnetic field. So that's the energy that's actually emitted from within the body in an MRI scan. And the proportion of hydrogen molecules differ according to different brain regions. Obviously, more hydrogen molecules in the cerebrospinal fluid as opposed to some a structure like the caudate or the putamen. So you can see then that the MRI image is much finer, much more distinct. We can see the corpus callosum. We can actually differentiate gray and white matter. We can see the fluid in the brain and things of that nature. So it shows up well on the screen, but it doesn't show up well on the projector. Positron emission tomography, or PET, is when we inject radioactive molecules into the bloodstream, or we have people inhale radioactive molecules. And these molecules release particles that are detected by the PET machine or the PET camera. And then a computer reconstructs variations in how dense the flow of those particles is, and it can actually localize where those particles, those radioactive particles, came from. And so then an image representing areas of high and low blood flow or high and low metabolism can be produced. The PET scan was introduced in the 1980s. Again, it produces an image of the distribution of a radionuclide or a radio-emitting radioactive substance located in the subject's body. And we can tag a lot of different substances so that it allows us to look at blood flow, metabolism, or receptor distributions, things like that. Drug distribution. Blood flow is most common as a kind of an indicator of the moment-to-moment brain function, because areas of the brain that are more active are going to recruit more blood flow to them. And so we would see an increase in the blood flow to the areas of the brain that were presumably more active. And this is basically the technique of the PET imaging. There's a positron, which is a negatively charged electron, or I'm sorry, a positively charged electron. It collides with an electron, which has a negative charge, and that collision between the positron and the electron produces a gamma ray. That gamma ray is emitted, two gamma rays actually, in equal and opposite directions, and those two gamma rays are detected by little detectors that are located around the person's head. SPECT, or single photon emission computed tomography, is this is a SPECT camera, and instead of two photons being emitted at a 180-degree opposite phase, there's only one photon, hence the name single photon emission computed tomography. And it uses a compound called TC99HMPAO. It's got a long and complicated name, but it has a half-life of about 6 hours. Some of the PET compounds that are used have half-lives of about 2 hours or as low as 2 minutes. And the PET tracers they emit the positrons, and as I mentioned, when a positron collides with an electron, it produces an annihilation event, which is the production of these two gamma rays. And the resolution is pretty good. It's about 4 millimeters. This is just a little bit about the physics of MRI, but I kind of explained to you that the molecules of the hydrogen atoms are oriented all in the same direction on the same axis in a magnetic field. And then radio frequency energy kind of knocks them out of alignment, and we measure the energy taken for them to return to alignment. And that's what actually produces the differences in concentration of water or hydrogen atoms or protons is what we're measuring with MRI. Structural imaging generally provides anatomical detail only, so we're limited to CAT or MRI or CT scans or MRI. Functional scans provide both anatomical detail as well as information about the functional activity of brain regions. Again, it's the metabolism, the binding of receptors, the blood flow, and things of that nature. So we have SPECT, PET, and fMRI as functional brain imaging techniques. Usually structural scans are outside-in scans or transmission scans. So a radiation source is applied or transmitted through the body, and the tissue density affects the path of radiation. So the alteration of the path of the radiation is used to reconstruct the image. So if I had a light and I shined it very brightly on my hand, that would be an example of a transmission scan, because my light is very dense, and my hand is very dense, and it doesn't allow light to go through it. So the image on the background is sort of reconstructed then by the difference in my hand's ability to let light pass through it. The functional scans, you can think of them as sort of outside-in or emission scans. So we have a tracer that's injected into the bloodstream, or we use something that happens within the body itself, in the case of MRI,